So if you have attended my monthly webinars before, you know that I speak for some time and then I always make it a point to leave time at the end for questions. And I love your questions. And thank you very much for investing your time. And what it tells me is that you are interested in brain health. So the reason I decided that 2022 is going to be the year of the brain for me was a few things. Number one, I decided that unless I focus on my brain health, I will not be able to help my patients either. So I decided to delve into a little bit more into the research and things like that to find out what could I do personally and how could I help my patients deal with their brain function and maintain their brain function. So the problem is with, and when I talk about brain function, it does not necessarily mean that you have dementia today or you have dementia in your family. That is important, no doubt. And I'm coming to prevention of dementia very soon. But before that, it's also important for your day-to-day functioning because your brain decides everything. Your brain decides how well you perform at your work, if that is something very important to you. Of course, it would be. It also decides your relationships, how you interact with other people, how you interact with your loved ones, how you interact with your, workmates. It decides what kind of decisions you make in terms of your finances, which is extremely important, whether you should be saving money or you're going to spend all of it and, collect a lot of debt. That is also decided by your brain. So good brain function is important for every area of anyone's life, for all our lives. But most of us, all of us are concerned about cognitive decline, over the years down the road, because we are afraid of dementia. And that applies to doctors and those of you who are here today, I'm sure as well. The problem with, so dementia, I'm not going to talk about dementia in details, but the most important thing to remember is Alzheimer's disease is one of the dementias. There are others as well: vascular dementia, frontotemporal dementia, Lewy body dementia. But Alzheimer's is the most common dementia. So sometimes the term dementia and Alzheimer's are kind of used interchangeably, but there are a lot of commonalities between all of them. And as people who are treating patients with Alzheimer's, they say that many people don't have, one type of Alzheimer's. There are many mixed types as well. Not one type of dementia, sorry. Many of them have mixed types as well. So if you are here today because you are interested in, let us say, vascular dementia, the things I'm going to talk about would apply to you as well. Because the other thing is, what is good for the heart is good for the brain as well. So though I'm going to talk about brain health essentially, you will realize that it applies equally to heart health, it applies to gut health, it applies to health overall. And the reason I decided that brain health is something I need to focus on is, number one, we do not have any good treatment for Alzheimer's today. When I say treatment, that means curative treatment. That means you take a medication and Alzheimer's will be cured and the person will stop having all the symptoms. There are medications to manage symptoms of Alzheimer's, but there are no curative treatments. One of the reasons is because Alzheimer's is not one disease, it's many different things that come together. The other important part is it is possible to reduce your risk for dementia, to prevent dementia. And dementias like Alzheimer's and vascular dementias, all the others as well. So that is what, as a functional medicine doctor, that is what excites me, because prevention is an area where, functional medicine doctors can work very well in that area, because that is where lifestyle change has a huge impact on that. And Alzheimer's actually starts 20 to 30 years before you actually develop any symptoms. So when is the best time to start thinking of your brain? As I say, it's never too early and it's never too late. So even if someone has symptoms of mild cognitive impairment, MCI, that is supposed to be pre-Alzheimer's, Even in those people, many of the interventions, lifestyle interventions, dietary modifications, certain supplements have been shown to help. Now, I'm not going to make some, major claims like, yes, I can help someone cure dementia with just lifestyle changes. No, it depends on where they are in the journey. But prevention, yes, absolutely, it is possible. And again, the usual disclaimers, whatever you hear today on this webinar is not to be considered as medical prescriptions. Even if you're my patient, this is not applicable directly to you unless I've told you at a one-on-one consult. So I am going to start off with sharing a screen. And at the end, what I will do is, let me see how it goes. I might pause in between and take a few questions as well, so that you can ask the questions while it is still fresh. And please feel free to ask your questions either in the chat box, or I think I can also unmute you, whichever way works for you. So you can see this long list. Now, the good news is I'm not going to talk about all 10 of them because I want to be mindful of the time. But some of these numbers I have talked about before: blood glucose levels, blood pressure. Blood pressure, in fact, I think 2 or 3 months down the line, I'm going to talk about natural strategies on managing blood pressure, or hypertension actually. And blood glucose, though the topic is exclusive for next month's webinar, I decided I was getting a lot of questions about what is a normal blood glucose level, particularly for the brain. So I decided to start off with that this month, but there is always more to talk about blood glucose levels all the time. Chronic inflammation, you know that chronic inflammation is related to 90 to 95% of all disease, and not just cognitive decline. HSCRP is a blood test. You can get that done anywhere in the world through your doctor. Waist circumference, so having belly fat is again an important risk factor. Sleep duration, short sleep duration is one of the major, it could be an indicator of Alzheimer's down the line. Now, then sitting risk, if you spend a lot of time sitting continuously, that is again another number to know. How long do you sit continuously? Now, when it goes to sleep duration, and I am sure I've covered that in some other, either a podcast or a webinar before, one thing that a lot of people don't talk about is long sleep duration and what it might indicate. So if someone is sleeping for longer than 9 hours regularly, it's not like you are catching up on your sleep over the weekend, not that kind, but the type where you need to sleep longer than 9 hours regularly, it could be an indicator of cognitive decline or mental health challenges as well. Eating window, how long do you eat and how many times you eat? Omega-3 index is a test for the omega-3 fatty acid levels in your blood. I will talk about that today. Alcohol intake, social isolation. Those are, again, I'm mentioning, I won't go into details. With alcohol intake, recently there have been quite a few papers which have shown that even mild alcohol intake, and I love red wine, so it applies to me as well. Even mild alcohol intake, so that for a woman would be, so 1 glass of red wine is about 5 ounces. So 1 glass of red wine every day for 7 days in a week, anything that level or below is considered to be mild. Even mild alcohol intake has been shown to reduce brain size. And obviously you don't want your brain size to be smaller. So no good news about any amount of alcohol actually, unfortunately, but then there it is. So blood glucose levels, what are the things I'm going to talk about? And again, some of it could be new information for you. Some of it could be things you already know. And another important thing is a lot of this may not be applicable to you at all. And what do I mean when I say that, optimal blood glucose levels is, it is different for different people, number one. And if you have diabetes, there are different parameters for you, because a person who has diabetes versus someone who has not been diagnosed with diabetes today, the management is different. How you reach an optimal blood glucose level is extremely important. And as I said, for many of these strategies, you do need to be, in consultation with your doctor. And uh, some of the areas your doctor may not be able to help you, particularly if they are not trained in therapeutic lifestyle change. So whenever we talk about, blood glucose levels, my levels are normal, people will tell me. And I have to ask, which levels are you talking about? Is it your hemoglobin A1C? So most people test for a hemoglobin A1C, and that has been the practice practically everywhere in the world because it is easy to do. It's a one-time measure. But at the end of this webinar today, you will realize why hemoglobin A1C may not be the best measure of blood glucose levels, and what are the other parameters we look at. The reason is there are some newer devices available where we can continuously monitor blood glucose levels. You wear a sensor. I'll talk a little bit about that. There are many different types available in different parts of the world. Some of them covered by healthcare, most of them are not covered by healthcare if you do not have diabetes. So the numbers, time in the names, time in range, and glycemic variability, these are probably two terms which many of you may not be familiar with unless you have been doing continuous blood glucose monitoring. So those, we are getting to know more about what what are the important parameters about blood glucose levels. Is hemoglobin A1C, which you do once in 3 months, and it usually indicates an average level. And many of my friends and patients say, I don't want to be average. I want to be much better than average. So those are few things to remember. Hemoglobin A1C may not be the best measure of blood glucose levels. So I wanted to talk briefly, and again, this is not about continuous blood glucose monitoring, but many people will ask me, what do you think is the best way to measure? And I say that if I had an option, I would put everyone onto a continuous glucose monitoring device where you wear a sensor for 10 days to most of them about 2 weeks. There are some newer ones which they are not available in Canada yet, which you insert it once and it can measure your blood glucose levels for 6 months continuously, which is usually connected to an app or there is an external reader. And the reason this is interesting and exciting is you don't have to do finger sticks. So otherwise, the traditional way of checking blood glucose levels, if you have diabetes or you know someone who has diabetes, is getting one of those glucometers, and there's a lance, and you do a finger stick and you put that into the drop of blood into, you know how to do that. So that is a glucometer, and monitoring blood glucose levels using those devices, that is called SMBG, self-monitoring of blood glucose. But a continuous blood glucose monitor is also an SMBG because you have that sensor on, and most of the time it's an app. You just take the app next to the sensor and it can record your blood glucose levels. So the good thing is, and all of them check your blood glucose levels in the background. So at the end of the day, some of them, depending on which device it is, they are measuring your blood glucose levels every 5 minutes to 15 minutes intervals. Now, it is absolutely impossible for anyone to keep doing finger sticks for that many times in a day. And that is the reason why these continuous blood glucose monitors are going to change, management of diabetes specifically. And they have already changed. And when I talk about diabetes, I'm talking about type 2, not the type 1, the autoimmune diabetes, where people don't make enough insulin. But it will also change a lot of things for people who do not have diabetes today, because diabetes is not something that develops overnight. And why am I talking about diabetes when I'm talking about brain health is having diabetes increases your risk for cognitive decline many times over. That there is enough data over many years that is known. But the concern is, what about those people who are pre-diabetic today? Are they at a risk for cognitive decline? The answer, unfortunately, is yes. So recently there was a paper which showed that if people have higher than optimal blood glucose levels in their middle ages, in the 30s, and high triglycerides along with that, their risk for dementia down the line is much higher. So in fact, there is a a way of thinking which says that Alzheimer's is considered to be type 3 diabetes. So there you have it. These are the problems of blood glucose. Now, The two important the variables that we are very interested in, because they give us a whole lot more information. Now the question is more information better? In some ways it is better. So one is time in range and the other one is glycemic variability, GV. It's easier to remember as TIR and GV. So I'm sorry about this very complicated slide. The reason I'm showing this is you can see that this is something that came up in 2019. So the CGM devices are fairly new, and if your doctor is not familiar with them, I mean, don't blame him or her, because number one is these devices are new. Number two is it does involve, quite a bit of, it's not a simple thing as you just go to the doctor with the report. What do I mean by that? Now, your blood glucose measurements on a CGM, you wear a device and you get your blood glucose measurements done. If you are not also tracking your food, your sleep, your daily movement, your steps, then that blood glucose data is not enough. So this is where I'm working on a diabetes project in India, and people will say now they are not using the CGM devices because various reasons. So they do SMBG, and there is one blood glucose number available because they have sent it on the as a message. And then I'm saying, I don't get any context. Like, was it after food? How long after food? Was it before food? What was their fasting blood glucose levels that day in the morning? So my point is just wearing a sensor and getting your blood glucose measured by the device in the background every 15 minutes or every 5 minutes. And at the end of 2 weeks, you go to the doctor and he or she gives you a PDF and says, you're doing well, you're not doing well. That is not enough for me. So here we can see that for different types, so type 1 and type 2 diabetes, you can see the target range is different. And the good thing about this graph is it shows the units in both the Canadian units. So the millimoles is the one used in Canada, milligram per deciliter is used in the US and India and other countries. And I think in the UK is millimoles as well. So I wish the whole world followed one type of units. But anyway, you can see that it is different for different people. Now, pregnancy is a time where very, very strict control is necessary. So you can see that here the time in range, so the target range, in pregnancy, the lower limit is also lower, it is 63, whereas for other people, it is, so let us say we take, older high-risk people in type 2 diabetes, if we look at this one. So the target range that people want to aim for is between 70 to 180. Now, I have asked, again here as well, 70 to 180. I have asked a few diabetes doctors about why are they aiming for 180 as the upper limit? Because in my world of functional medicine and optimal brain health, upper limit of 180 is too high for people who are not older, who are not at risk for hypoglycemia. So hypoglycemia is when your blood glucose levels are consistently below 70 and you have symptoms. And that is more of a problem for people with diabetes. People who do not have diabetes, hypoglycemia is not really a problem. My blood glucose levels have gone down to 3.2 and I have not felt anything because this was in the middle of a 20-hour fast. So bottom line is it's different things for different people. So you do need to discuss this with your provider, and your provider also needs to have the right knowledge. So the upper limit of 180 is, again, this is my suspicion, because most of the diabetes doctors I talk to are used to using pharmacotherapy. So that is using prescription medications to manage diabetes better. Many of them are not trained in the lifestyle and pharmacotherapy approach, which is what is more exciting, because this 180 milligram per deciliter upper limit, if someone can achieve a lower limit without the addition of another 10 drugs, then, but instead of adding more medications, they are able to dial up their lifestyle changes. That is a much better way, because lifestyle changes don't just impact your blood glucose levels, they impact your long-term brain health, your immediate mood, those, up and down, one moment you're irritable and angry and hungry, Next moment, you're feeling fine. Those mood swings, things like that, those are also related to your blood glucose levels going up and down dramatically. So the point in sharing this rather complicated slide is this is based on, there are guidelines available. This is from the American Diabetes Association, and there are similar guidelines for other places as well. So this is the sample report from one of my patients. This particular patient is about 56 years old. He has had diabetes for 8 or 9 years, South Asian ancestry. He's had 2 angioplasties done. So bottom line is, again, here what happened is, so you can change the settings in the device. And so my recommendation for him was that you need to keep it below 7.3. So that is below 140, because he has heart disease. And the only diabetes medication he is on is metformin. So which means he is not on insulin, he's not on 20 other medications. He's recently added a SGLT2 inhibitor, but I'm not going into the treatment of diabetes. What I wanted to show is, ideally what you want to look at is for your blood glucose numbers to be in the target range. And again, if what we usually do is, depending on where you start off at the baseline, this is applicable for people with diabetes. For people who don't have diabetes, you don't need an upper limit of 10 or 180. You need to keep it below 140 or below 130 actually. So below 7.3 or below 7.7 is what we would ideally like it to be over a period of a long period. And this is where, initially we don't necessarily always push the target very strict, but over a period of time, it is possible, like I said, not by adding another 10 medications, but if you can dial up your lifestyle changes, it is possible. So for him, the suggested target was 3.9 to 7.7, but somehow I think the settings were not okay. So here you can see that he was in the target range, because this target range was higher 100% of the time. So ideally, most people would say between 70 and 90% of the time if they are in the target range, but I have stricter criteria for people who do not have diabetes. So 90 to 100% of the time, because the other reason is, if you aim for a higher, stricter target, the likelihood of you achieving that is higher quite often. And again, this is not medical advice. You need to talk to someone who understands, who's your physician. And here, very high levels were also 0. He didn't have like super high, and he didn't have lows and very low. So both of these. So there, in the previous slide, I had shown that there is a certain criteria. So it should be less than 4% of very lows. So you don't want the very lows. You don't want the very highs either, because it causes a lot of problem. So here, this is what a usual report looks like. So one important thing we always check is, how long was the sensor active? Because if the sensor is not functioning well, then it's obviously not going to give you the correct information. So if this was active for just 40% of the time, then obviously we cannot really check that. Now, average glucose was 5.9 millimoles per liter. Here it says the goal was to make it less than 8.6, but our goal is different. So glucose management indicator, these are all numbers that would automatically come in your report, any sensor you use. Here is what I wanted to show on where CGM, so that is a continuous glucose monitoring, versus doing a self-monitoring of blood glucose using a finger stick is different in the sense of the amount of information available. So again, this is not exactly to scale, because usually I like more frequent time intervals measured here. But you can see this person, this is the same patient. His target range was between 3.9 and 7.3. Now here, this was, so 00 is midnight. You can see that it went up dramatically. Very likely he's someone who has dinner some days very late in the evening. Oh, this is another interesting thing. So when we were, so I'm working with this company, and we are going through the data, I said, I need to know the day of the week. They said, how does that matter? Like, why would the day of the week matter? I said, oh, it does, because many people, go for parties over the weekends, and they don't eat the same way. If they eat outside the home, they eat very late in the evening, that is going to change their blood glucose level. So I need to know the day of the week. Or if they have, let us say someone has a regular weekly lunch with friends. So does it mean that they make poorer food choices on that day? So then they need help in making better food choices. So it's every piece of information, there is a reason when why I ask for it. And some of the team members are thinking, why do you need such detailed information? I said, yeah, because I focus on solving problems in the practical world, in the real world. And a lot of this information was not available to us before. Anyway, I am digressing. So what I wanted to highlight here is, let us say this person had food at about this time. Okay, so before that, he measured his blood glucose levels with a finger stick. Let us say he does not have a CGM measuring it. So he measures here. Sorry, what happened to my cursor? He measures here and he measures here. Now, both these numbers are very much in the range that we'd like it to be. But what about this major peak? He is not going to know about this major peak because he did not check his blood glucose levels as often. And obviously, how many times are you really going to keep doing the finger stick? So some people actually have a peak blood glucose level, not at 2 hours or 2.5 hours, they peak at 1 hour. And if you don't check at 1 hour after having food, you won't know what your 1 hour levels are. So it is possible, as you can see in this, as they say, a picture is worth 1,000 words. You can see if you measured here and here, you'd be very happy. My numbers are very good. They are in the range. See, I ate food and it didn't go up so much, but you would miss this peak. So that is why the continuous blood glucose monitor is important. And again, like I said, it's different things for different people and everything is in context. Now you can see that he had quite a few peaks, and if he hadn't measured his, with a finger stick, he would have missed all of these and not known that his blood glucose was actually going up a lot. This is just one day and so many peaks. So usually it goes up after food. So definitely it's dependent on what food he had eaten. But again, I didn't have all the context food information. So when I say context food is like, what did he eat here that it pushed it so much? And what else did he eat along with that particular food? And that is something I've been talking about on other webinars. I'll not cover about food here, but I will talk about it sometime in probably the next one. This is another very important measure, which we didn't have the ability to capture this information when we did not have a CGM. So this is again data from a person's continuous blood glucose monitor device. So you can see, compare the two of them. Both this person, subject 1, has a hemoglobin A1C of 8%. This person has a hemoglobin A1C of 8% as well. But look at all the numerous highs and the numerous lows. Now, of course, this range is much higher, and I suspect this is someone with type 1 diabetes. But the bottom line is, both are at hemoglobin A1C. So going back to why I don't rely on hemoglobin A1C only, and you can see all these super highs and super lows. These cause a lot of problems long term. So this is high glycemic variability. And these are calculations which would automatically come in your report. And this is a person with low glycemic variability. So they don't have the highs, too many highs and lows. But the average hemoglobin A1C is the same for both of them. But the two are completely different in terms of brain health, heart health, kidney damage, peripheral nerve damage. And these are people with diabetes I'm talking about. But in people who do not have diabetes, so we do have lots of studies where they got people to wear these continuous blood glucose monitors. And many of these people were shocked to know how high their blood glucose levels went up when they ate certain food, which they thought were very healthy. Things like a whole grain toast. Some of them went into, blood glucose levels went into the diabetes range when they had a whole grain toast. Or some people were surprised by the response to things like popcorn and a whole lot of food which they thought were not that harmful, or some of them even thought they were healthy. You're supposed to have healthy whole grains, but those were like big shocks to a lot of people. For many of my patients in India, milk tea is a big shock. They never realized that milk tea was so bad for their blood glucose. So this is to illustrate this thing at the same hemoglobin A1C level. This person is way safer than compared to this person. And so many times where the blood glucose levels has gone down so much, that is not good at all for their, again, for the heart, brain, nerves, every kidneys, every system you can think of. So what is one of the major factors that decides glycemic variability, that makes your glycemic variability worse? The biggest source of, high glycemic variability is the rapid onset of hyperglycemia. That means high blood glucose levels due to consumption of carbohydrates. So the more carbohydrates you eat, and again, in what order you eat, all those I have talked about them before. I'll talk about them again, probably next month, is dependent on the carbohydrate content. So here you can see on this, this graph, when you eat more of carbs, your blood glucose levels go up very high, dramatically, very soon. So you can see that 1.5 hours, this one can peak. But the unfortunate thing is it also falls drastically very soon. Versus when you eat protein, it is, number one, it is lower blood glucose levels, and it is more evened out over a period of time, and likewise with good quality fat. So both of these will give you more even blood glucose numbers and less of glycemic variability, versus eating a lot of carbs and then adjusting your diabetes medications because you have decided to eat something that was not supposed to be on your list. So this glycemic, if you are someone who has a higher glycemic variability and you are wondering what is going on, food is one of the, food decides 95% of your blood glucose levels. Then comes, stress and movement and all those things. So this is important to keep in mind, glycemic variability. And I am so shocked to hear many people with diabetes say, oh, it doesn't matter really once my blood glucose levels go outside the range, because they will come down after some time. What goes up comes down. And if I go for a walk right now, it will come down. But that is not absolutely okay for long-term health, particularly for the brain. Because what happens is these wildly swinging blood glucose levels increase something called oxidative stress. And higher oxidative stress is related to all sorts of worst outcomes for the brain, heart, kidney, eyes, everything. So it's not just only for the brain, but for the brain, definitely there is a huge impact. So this is a fairly recent paper from 2020, where they compared type 2 diabetes patients with stable glucose levels versus those with not stable glucose levels, so fluctuating glucose levels. Another thing you'll notice that most of the studies, if they are a clinical study, are done in people with diabetes, because using a continuous glucose monitor in people who do not have diabetes is not a very common thing now. So a lot of people who are interested in performance, who are interested in better cognition, who are interested in health, they are biohackers. Those people decide to wear one just because they want better health. They don't want dementia down the line. So my point is, you may not find a lot of literature on people who do not have diabetes, but the wildly swinging blood glucose levels and how high some of the high numbers go would impact everyone, whether they have diabetes or not. So again, these are a whole bunch of cognitive testing, the Montreal Cognitive Assessment. So that's called the MOCA test. And then there was one more, the degree centrality is a brain imaging technique. So all of these areas, they found that those who had stable blood glucose levels versus fluctuating glucose levels, fluctuating was much worse. So higher glycemic variability is related not just to poor brain health, it's related to a whole lot of other complications as well. Now, just an aside, when we talk about brain health, one of the reasons is most people may not know what is going on with their brain health, because in addition to blood biomarker, there is like no one single blood test which will tell you your brain health is good, your brain health is bad. I wouldn't have listed 10 of the numbers. So these are just 10 that I listed. There are a whole lot more. So in the world of cognition and detecting assessing brain health, there are two major factors which are not easy to do or get done. One is neuropsychiatric assessments, and the other is brain imaging. Because in most countries around the world, usually people are not going to go for a brain imaging or neuropsychiatric assessment unless they have symptoms, because it cannot be justified. Versus what I am talking about is things, looking at things before something happens. So again, going back to the glycemic variability, it does have an impact on cognitive function and other functions as well. So I'm sure now I have helped you understand why hemoglobin A1C is not the best measure. So again, three patients, all of them at 7% of hemoglobin A1C, but here the greens are the ones that are again time in range is, so this one is 63%. And this person is 100% of the time in this range. And this person has also had 8% of hypoglycemia. That is very high. And look at the amount of hyperglycemia, 29%. And this person also, you can see the hypoglycemic episodes were much higher, and time in range was shorter. But all of them, if they, at the end of 3 months, they have their hemoglobin A1C measured, they are all at 7. But all sevens are not the same. That is what I wanted to illustrate. And I have sent this slide as a screenshot to so many people, because I keep getting asked, what do you mean hemoglobin A1C is not the best measure? So going back to this question of what is an optimal blood glucose level, again, my answer as always is never simple. So it depends. It depends on, number one, whether you have diabetes, whether you are older, whether you are younger, whether you are focused on getting your numbers in the optimal range. So in the absolutely ideal world, so this is what I would, I personally, I aim for is between 70 to 130, 90 to 100% of the time. I would rather it is 100%, but it's not 100%. Usually last time I checked, it was about 95% of the time. But this upper limit of 180 for people with diabetes, I'm not saying this is for people without diabetes. Without diabetes, these are the numbers you need to look at, not 180. My suspicion is because lifestyle change in diabetes, intensive lifestyle change is not easy to do, number one, and it needs a big team. A single practitioner cannot provide an intensive lifestyle management program at all. So, like I said, if it means reaching a lower level than 180 by the addition of 20 medications, that is not what I'm talking about. What I'm talking about is a combination of, some people will need some medication. And I have patients who feel that that's like a personal failure if they have to be on diabetes medications. That is not something I would suggest or even try to say that if you are on medications, you are a failure. No, some people will need medications, but they may need a much lower dose. They may not need very high dose. It may not be getting worsened. But usually it is, again, it depends. If you're a newly diagnosed newly diagnosed person with type 2 diabetes, you have a very high chance of reversing that, what we in medical terms call remission of type 2 diabetes. Means you have intensified your lifestyle change to a point where you no longer need the medications. And today we know how to help you do that. And if you are someone who's not diagnosed with diabetes today, but you find that your blood glucose levels are climbing, we know what to do with you as well. You have an even better chance of never having to go on to diabetes medications at all. But if you should need some medications, my suggestion and my recommendation is, please don't think that that's because you are not good enough, you are not able to do all the things that you should be doing. It's a personal failure. It's none of those. But not reaching target blood glucose levels, with whether it's with a combination of lifestyle and medication, that is not acceptable, at least to me. And I'm sure it won't be acceptable to you as well. But again, everyone makes their own decisions. So I'm going to pause here for 2 minutes in case you have any questions. Feel free to type in the chat box, or I think you can raise your hands and I can unmute you for you to ask. And so I'll just wait for a few minutes and maybe enjoy one more sip of tea. Or you can even ask in the question and answer box or chat box, or raise your hand. Whichever is comfortable for you, please go ahead. Okay, at this point, I don't see any questions, so I am going to continue. There will be more time for questions at the end as well. And I'm going to go back to my this is again, when we talk, whenever I talk about brain health and who should be interested in brain health. So a lot of people, researchers who work in dementia prevention, they'll always say anyone who has a brain needs to think about brain health. And I find a lot of people think that, oh, dementia is something that's going to happen late in life, after I'm 60, 70 years old, and now I'm in my 20s and 30s or maybe younger. I don't need to bother about brain health today. Well, not quite right. So what did they do? So this is a study, I think this was done in Texas, where they looked at the neurocognitive benefits of stand-based school desks. So they had these standing desks, and I am not sure, maybe these could be sit stand, because obviously we don't recommend, no one recommends that you stand all the time. So what they found is when high school kids were given these standing desks, their cognitive performance improved. And that is not a small thing, because normally in schools, I remember we used to sit the whole day, and it was only interrupted by a lunch break when we were supposed to go out and play, or we had a physical activity class. But rest of the time we sat. So every class was about 40, 45 minutes. And I don't know if things have changed now. So hopefully they have changed. And if they haven't, maybe if you have kids who are in high school, you could have this conversation with the school board. I don't know how easy it is to implement, but you could also implement this for yourself at home. The point I wanted to bring up here is these things, continuous sitting and not going out into nature, getting daylight exposure, not being physically active. These things impact people who are much younger as well, who are not thinking of dementia at all. But I don't meet anyone who's not interested in better performance, in doing well in academics, all these things. So if you have young teenagers in your family, or you have kids or grandkids, and you are trying to tell them, oh, you need to stop sitting so much, watching TV and gaming and all that, because you're going to get dementia 70 years down the line, they're not going to be interested. But if you tell them that, no, this might help you actually improve your academic performance in school next month, they might be more interested. Or if you can tell them that, it could improve your gaming skills, that is going to be much more interesting to them than what is going to happen 50 years down the line. So omega-3 index. Now, omega-3 fatty acids, I have talked about them before. They are extremely important for the brain. And omega-3 fatty acids are essential fatty acids, meaning our bodies don't have the ability to make them. So if we cannot make them in our bodies, what does it mean? It means we have to get them from food and supplements. And why do I say food and supplements? It is absolutely impossible for anyone to get all their omega-3s from only eating food high in omega-3. And which are the food high in omega-3? So my associate Mikhal and I did a video where we showed actually how much omega-3 is and which particular food. Yes, wild fish like salmon have higher omega-3 levels, but some of the other things like lamb, they have omega-3s as well. Now, in Canada, the recommendation is 2 servings of fish a week because of the high levels of mercury in many of the fish. So that mercury is very toxic for the body. By eating 2 servings of fish a week, you are not going to get enough omega-3. So in my personal opinion, which is shared by a lot of people in my functional medicine world, is you cannot get enough omega-3s by just eating more fish or even more meat, because you will never be able to get that kind of levels. So we say that, if you can test, why should you guess? So don't guess when you can test. So omega-3 index is a dried blood spot test, which is available most places in the world. So at the end of this, maybe in another 1 or 2 days, I can send you a link with a discount code. So there is one test which is available in the US and Canada as well. There is another company out of I think the company is out of Finland, where they have services in many other parts of the world. But it's a dried blood spot. So you get the kit shipped to you. You can do it yourself. You put the blood spots on a piece of paper and you ship it off to the whichever, whether it's the US or the Finnish company. And after some time, they will send you a report which will show you how much of omega-3 you have, how much of omega-6. And the US report also shows you the levels of trans fats. So trans fats are the worst possible fats. You don't want any of them. Food sources of trans fats are all the baked stuff and, cookies and biscuits and cakes and you name it. So those are the hydrogenated, bad, really bad fat. And all over the world, there is a big, big project of getting trans fats level to zero in food, in packaged food. That's not yet happened everywhere, but people are trying. So lower the omega-3 index, poorer the brain function. And when I talk about brain function, it's not necessarily only dementia and cognition. It is also things like mood disorders. So omega-3s, you will need, yes, I'm not suggesting that don't eat fish, but relying only on fish twice a week to give you enough omega-3s is not going to work out. So you need to, ideally, you need to check your omega-3 index. And what is the ideal, it comes as a percentage, the report, and you will see in the report, it shows you clearly what it is. So for some people, having a higher omega-3 index of between maybe 10% instead of 8%, 8% is kind of the better level, may be necessary for people who have the ApoE4 gene, which raises your risk for dementia. I'm going to talk about ApoE4 gene on a podcast. Only thing I want to tell you is if you have the ApoE4 gene, it's not necessary that you're going to develop dementia 100%. And if you do not have the ApoE4 gene, 1 or 2 variations, even that does not mean you're not at risk for dementia. So it is because a lot of people talk about it, so I'm going to talk about it on a podcast, but someone who has the ApoE4 gene, it's possible that they need a higher omega-3 index. And another important factor to remember is omega-3s don't work alone. So they will work along with B vitamins. So you need to ensure that your B vitamin levels are normal as well. And social isolation and loneliness, in fact, this is so important that in some studies have shown that it is even worse than smoking. So we all know that smoking is bad for your health, and particularly given the ongoing pandemic, social isolation has become more common. So social isolation is when you are not connected to a lot of people on a regular basis. So every day you don't talk to other people either on the phone or you don't meet in person. Because of the pandemic, I know it's not always possible to meet everyone in person, though now of course things are opening out. So that is one thing. And loneliness is you may be living with a lot of other people, but you still feel very alone. Both of those are major risk factors for cognitive decline. And again, I'm not a specialist. I'm not an expert in how to deal with all of that, but there are a lot of other people who can, help you in. So number one is, do you have someone you can call in the middle of the night if you have an emergency? Are there at least a few people in your life that if you call them, you can rely on them to give you the right advice? And many of them more importantly, when you talk to someone like that, do they make you feel worse? Then maybe that is not the person you need to talk to as often. I'm just kidding, but you know what I mean. There are some people in my life, there are some people, all they do is, this is not going right, that is going bad, this one did that to me. And sometimes I have to say, just pause, Let's focus on what are the things that are going right with your life. And as meditation teacher, Dr. John Kabat-Zinn says, if you are breathing, then there are more things going right with you than wrong. So yes, from social isolation and loneliness. Another important thing is many people think that if you're living alone, you are isolated. No, I know a lot of people who live alone, but they have a very busy social life. So living alone is not directly related to isolation and loneliness, but you might be living amongst a lot of other people and still feel lonely. So again, these are not the numbers. These are not all the things that I have talked about today, but they are all important. And I have talked about most of them or some of them at some point. So this is what I'm always trying to find out that what are there just like 3 to 5 numbers? If I had those numbers from someone on like a weekly basis, would I be able to give them some recommendation or help them troubleshoot something? So let us say this is a fictional, this is just an example, this is not an actual person. But if I got just these few numbers, blood glucose of 150 milligram per deciliter, this could be just random. One day you decide to just check your blood glucose levels 2 hours after eating food and it is 150. Again, like I said, it depends on whether you have diabetes or you do not have diabetes. If you do not have diabetes, 150 at any point in time is not a good number. If you're sleeping for 5.47 hours, is it possible that because of poor sleep, your blood glucose levels have gone up? And again, this blood pressure is definitely not normal. But again, with blood pressure, the same caveats apply. Does it mean adding another 3 blood pressure medications, or does it mean looking at more natural strategies to lower your blood pressure? Different things for different people. Mood, this is not a very good mood. Daily steps, 4,500 steps is considered sedentary. So you realize here, just by these 5 numbers, I can definitely say that there are so many areas this person can start improving. The most important question is, where do you start? So I am sure I must have mentioned this on other webinars before, that I am a certified Tiny Habits coach now. So Tiny Habits is a method developed by Stanford Behavior Design Lab head, Dr. BJ Fogg. So Dr. Fogg says that help people do what they already want to do. So let us say, for example, if this is you and you look at your numbers and you decide, okay, I need to make some changes. Where should you start? It depends on you, you know. So this is where, being prescriptive, which is what as doctors we are so used to doing, I would have said, do you realize how little you're sleeping? Why aren't you sleeping enough? Or do you notice how little you move? So where do you want to start? Like, you need to start increasing your daily step count. This is what I would have done earlier. But today, after being trained as a Tiny Habits coach, I would probably ask, where would you like to start? And if they say that I would like to just change my step count by 500 more steps every day, then the next conversation is, how can we do that? Because what Dr. BJ Fogg says is, if people do things that they already want to do and feel successful, that success begets more success. So that success will lead them to do more difficult things. Maybe that success of increasing just 500 steps a day will help make them feel successful because of the instant celebration, and that will help them maybe make better food choices next time so that the blood glucose levels don't go up so much. So then once the blood glucose levels go down and the steps increase, maybe blood pressure will come down because they start sleeping more. So everything is connected. Mood improves because of increased daily steps, and maybe you spend more time outside in nature getting daylight exposure. That helps improve your mood. And once your mood is better, you make better food choices. So everything is connected to everything else. That is what I wanted to share. But my major takeaway from the Tiny Habits course was helping people do what they already want to do, even if that does not seem to have a huge impact on their health at that point. They will be in a much better position to do more difficult things. And the Tiny Habits method, if you're not familiar with it, in another day or two, I'll send you a link. Feel free to join our free 5-day Tiny Habits for Brain Health course. and Jennifer Lee, who's the Assistant Director of the Tiny Habits Academy. She and I have an online self-paced course called Tiny Habits for Brain Health available. So you'll receive links to both of those. Because I'm probably not going to make a lot of sense talking about the Tiny Habits method if you have not read the book or you're not familiar with the Tiny Habits methods. Join us for the free course. Thank you very much. And now I think that was probably the last slide. And you know where to find me. So please feel free to ask your questions. And thank you very much for joining me here. We have 5 more minutes left. If you have questions, go ahead, either raise your hand and I will unmute you, or feel free to type in the chat box. Okay, I can see one raised hand. I am going to let you speak. Okay, go ahead. I think, Sham, I cannot let you see the video. Let you switch on your video. You need to unmute yourself. And yes, I am going to come to your question about cholesterol after Sham asks his question. Sham, you need to unmute yourself. Okay, oh yeah.
Can you hear me?
Yes, I can hear you clearly, loud and clear. Go ahead.
Excellent, excellent, excellent. Yeah. So you know my question, and I'm waiting for the answer. You know my question already.
What is your question?
About cholesterol.
Oh, okay. So the cholesterol question is yours. So is cholesterol level linked to brain health too? Yes. So the cholesterol question is, now cholesterol needs a much deeper dive and a longer answer. Number one is the brain needs cholesterol to function. So all of us have fat heads. But unfortunately, what has happened is cholesterol has become related to, you have high cholesterol, that means you are at a higher risk for poor heart health, poor brain health. Now, cholesterol is not as simple as bad cholesterol, good cholesterol. And I have talked about that on another webinar. One is, if you go and if you look at a traditional lipid panel, which all of you have gone through, it has something called total cholesterol. Then it has numbers like triglycerides, LDL cholesterol, HDL cholesterol. So these are the different ones. HDL is supposed to be the good cholesterol. LDL is supposed to be the bad cholesterol, but it's not as simple as that. High triglycerides, there is no doubt about that one, because high triglycerides is related to all the possible worst things in the world, including cognitive decline and heart disease as well. So total cholesterol can sometimes go up because of infections, because of suboptimal thyroid function. Both of those are some of the major factors. And there is, again, I don't want to make it sound very complicated, and I'm sure you've seen my webinar on cholesterol beyond good and bad. So that was one webinar I had done a few months ago. So one of the things is, it is not just what your LDL number is or your HDL number is. So total cholesterol can go up for other reasons as well. And sometimes it could be an autoimmune condition. Even COVID can change your cholesterol levels, because every cell in the body, particularly immune system, hypothyroidism is linked to high cholesterol. Yes, if thyroid levels are not optimal, cholesterol levels can go up. So autoimmunity can raise your cholesterol levels and change them to what is supposed to be more unhealthy. So there are many different factors. As a functional medicine doctor, what we do is we try to find a reason of why your cholesterol seems to be abnormal. The other important thing is we know a lot more about cholesterol now. So there is something else called an ApoB. ApoB is a test which you can do, I'm sure, anywhere in the world, but would depend. Some healthcare systems cover it, some don't. ApoB would be a much better number, because it indicates your unhealthy cholesterol levels much better. So it is much more than the standard lipid panel, which just shows your LDL and HDL, and your doctor will look at your LDL level and say, it is not in target, you need to get on to certain medications. So Shyam, I don't know whether that really answered your entire question, but it's not a simple answer.
One thing, Shabnam, it's about a couple of years back that one of my very close friends, he's a doctor. He's actually a very reputed cardiologist, and
Mhm.
he had a he had an issue that he got blank in the during some catheter operation or something,
Mhm.
and then he had a brain scan, and there's found that there's something in his head, and um, somehow it was. I understood at the time that somehow this process of Alzheimer's is related to this some kind of a I mean blood clot or cholesterol deposit in the head.
Okay,
Mm,
so that's
that,
a
that,
very
that is
important question. So
that is
number one, yeah, sorry, go ahead. Sorry, I'm
no,
interrupting.
as a layperson who has very fringe and very what I should say very scattered knowledge about medical sciences, and that reminds me that when you're talking of brain health and you're talking of cholesterol, that how these things are really related and what should be taken care of,
Okay.
especially when you talk of Alzheimer's, how these things could be somehow, if not completely stopped, but delayed or
Yes.
put forward. Yeah. Mm. That is something which I'm very much interested to know. If you
Okay.
have some, yeah,
So I
please go
think
ahead.
what you are talking about is the beta amyloid and tau deposits that people talk a lot about when you talk about Alzheimer's disease. So that is not the same as cholesterol deposits. But what you said about your friend, it's likely that there was like an obstruction to blood flow to the brain, which probably caused a stroke. So some conditions like stroke, Parkinson's disease are related to higher incidence of dementia. But yes, all the strategies that I'm talking about, maintaining better blood pressure, blood glucose levels, lower inflammation, those would help anyone. But when it goes to amyloid and Alzheimer's disease, there has been, billions of dollars have been spent trying to get rid of beta amyloid in the brain. But what researchers have realized that there are a lot of people who have amyloid deposits in the brain, but they don't develop Alzheimer's. And there are people who have, obviously, there are people with Alzheimer's who have the amyloid deposits. And all the research which was targeting the beta amyloid, like once we get rid of the beta amyloid, Alzheimer's will go away and we will cure Alzheimer's, they haven't quite panned out. So yes, amyloid is important, but that is not the only thing. Then they decided, okay, maybe we are not attacking them early enough. We need to start earlier. But even that has not really worked to a cure. So yes, what kind of deposits, that is important. Now I'm going to go over to there are some more questions. And I am sorry we have gone over our time, but I do want to reach your questions. So is cholesterol level linked to brain health? I think I've answered that. And so you advise to be cautious with alcohol. Don't we need to balance social happiness and health? I wish I knew the answer to that. Each one has to make their own decision. Now, every lifestyle change or whatever you're talking about, food, drink, movement, daylight exposure, stress management, everything is in the context of your life. If you are otherwise eating way more healthy, then the occasional alcohol is not going to get you right off completely off the boat or off the rails. But if that is a regular thing, then that could be a problem. Or if you're someone to whom it doesn't really matter what brain function is like down the years, then there are a lot of people like that who are not really bothered. And some of them unfortunately don't even realize that they have a problem, because I know a lot of people who I feel the brains have gone offline but they don't realize. So hypothyroidism is linked to cholesterol. Can high cholesterol levels be fixed without statins if I have hypothyroidism? Absolutely. And statins are supposed to target only the LDL, not total cholesterol, and they do not target triglycerides. So depends on which cholesterol you're talking about. Then I think that's it. Thank you very much. And if you have some question that you can think about later on, please feel free to email me, and you will receive a recording of this webinar today, and it will be posted on my YouTube channel as well. Thank you very much. So see you all next month, third Friday of the month. And the topic again next month is going to be blood glucose levels, because there's so much to talk about blood glucose. Thank you.
Thank you, Shabnam.
Thank you, Sham. Thank you for joining in.
Yes, thank you. Bye.
Bye. Thank you, Raju. Thank you very much. So see you next time. Bye now. I'm going to end the webinar.